our first session is a panel session on the management of kidney masses. Remember, not all kidney masses are cancer. So, a management of kidney masses and early stage renal cell carcinoma. We will have Dr. Abhinav Khanna, who is a colleague of mine, a urologic oncologist here at Mayo Clinic in Rochester, Minnesota, and Dr. Rebecca Hibbert, a radiologist who specializes in image guided therapies and procedures here at Mayo Clinic in Rochester, Minnesota, as well. As with all of our speakers, if you want to learn more about them, there's a bio in the digital program book that you should have access to. Thanks for joining, and we'll get started.
Thank you so much for the introduction, Dr. Leibovich. Good morning. My name is Abhinav Khanna. I'm a urologist here at Mayo Rochester. I'll be speaking about the management of early stage kidney tumors with a focus on surgery and sort of a surgical perspective. You can go to the next slide. So a quick outline for my portion of the talk. I'll give an overview very briefly about the epidemiology of renal cell carcinoma, provide kind of a framework or a very practical approach to how I think about patients who are presenting to us in our office with a kidney tumor. And then we'll talk a little bit about treatment options, focusing on active surveillance and then surgical options. We can go to the next slide. So, kidney cancer accounts for over 80,000 new cases in 2026, as well as 15,000 deaths in 2026. Consistently, kidney and renal pelvic cancer are ranked as among the top 10 most common cancers among both men and women in the United States. Next slide. I've listed here the types of kidney cancer or the types of renal cell carcinoma, the most common being clear cell renal cell carcinoma. Papillary and chromophobe kidney cancer are both slightly less common subtypes. And then there's a few very rare subtypes that we've clumped together just on the bottom of that slide. And we can move to the next slide. In terms of staging of kidney cancers, staging really depends on the size of the tumor and the extent of the tumor invasion into surrounding tissues or into the central part of the kidney. So for the purposes of this talk, we'll see on the next slide that, or this sort of portion of today's event, we're going to focus on early stage kidney tumors. We can go to the next slide. So that's focusing really on T1 kidney tumors. So tumors that are less than 7 centimeters. And sometimes we even refer to small renal masses as being T1A or less than 4 centimeters with no signs of invasion into blood vessels or fat surrounding the kidney. We can go to the next slide. So now we'll switch gears and talk a little bit about a very practical approach to early stage kidney tumors. Next slide. So when a patient comes to our office with a CT scan or an MRI showing a tumor in their kidney, very practically speaking, I think through two questions. The first question is, what is it? And the second question is, what do we do about it? Next slide. So in terms of that first question, what is it? Next slide. We know from research that's been done actually at Mayo Clinic over the last 25 years and kind of validated elsewhere, including, seminary work from Dr. Leibovich, most tumors in this size range do end up being small kidney cancers. So in the size range that we're talking about, 4 centimeters or smaller, about 80% of these tumors end up being kidney cancer. Next slide. But just because a tumor is cancer does not mean that it has or will spread to other parts of the body. So even though 80% of small renal masses end up being kidney cancers, very few of those will actually have potential to metastasize at that size. So again, in this size range that we're focused on, less than 4 centimeters, 1% or even fewer than that will actually have the ability to metastasize. We can go to the next slide. So then the next question is, should we do a biopsy of the kidney tumor? We can go to the next slide. So the way I think about biopsy is that, will the results change our management? So for instance, if you do a biopsy of a small renal mass, a small solid enhancing kidney tumor, You do a biopsy and it shows kidney cancer. Well, you kind of already were suspecting that. You had an 80% likelihood that that was going to be the case. And so you have to ask yourself, did that biopsy really change anything? Did it really give you any more information since you were already suspecting that this was a small kidney cancer? The flip side is if the biopsy shows no cancer, there can be some caveats there. So between 8 to 14% of the time, there's simply not enough tissue sampled to be able to accurately tell. And another 5 to 25, sometimes even 30% of the time, depending on the study you look at, a biopsy showing no cancer can actually simply be wrong. And so biopsies that show no cancer should be taken with some perspective and perhaps with a grain of salt. And we wonder how much that negative biopsy would actually reassure us. Next slide. So the way I think about this in a very fitting analogy these days is, doing a renal mass biopsy for a small renal mass is sort of like checking the weather forecast. So it's currently January, and some of us live here in Minnesota. So if we check the weather forecast and it says it's going to be cold and it might snow, you might say, well, that's obvious. And I really didn't need to check the weather to figure that out, right? So that's where you do a biopsy of a small renal mass. It shows that it's kidney cancer. And you kind of say, okay, I was suspecting that already. The flip side is if I check the weather forecast and the meteorologist says that tomorrow it's going to be warm and sunny, uh, I'm going to think twice before I put on a t-shirt and shorts, right? I have a healthy dose of skepticism about that biopsy result that says it's not cancer. So I take it with a grain of salt. It's possible, but you have to think a little thoughtfully about that. So on the next slide, we'll see, should we do a biopsy? The honest truth is, in most cases, we don't, but there are some times when we do. Next slide. So the American Urologic Association, the AUA, gives us some guidelines and recommendations about who to do a biopsy and who to not do a biopsy in. So first, we'll talk about when should we not do a biopsy. And here, really, the focus is we should not do a biopsy if that biopsy is unlikely to change plans, if it's not going to impact our management. So, for example, you have a very young, healthy patient, you're not really willing to accept some small degree of uncertainty associated with a biopsy, and we're likely going to treat that patient no matter what a biopsy shows, we probably shouldn't do a biopsy in that situation. The flip side is, let's say you have an older patient, maybe they're not the healthiest, they have other medical conditions, and you're more likely to manage that patient less aggressively, no matter what a biopsy shows. That's also a reason, perhaps, to skip the biopsy. Next slide. We'll see here, these are on the next slide. Yeah, so we'll see some reasons where you should do a biopsy. So if the tumor looks funny, meaning you're worried it's not a run of the mill, kidney cancer, and it looks like it might be something else, like an abscess or an infection or a lymphoma, or maybe even cancer from another part of the body, that's a great reason to do a biopsy. Next slide. It's also, you might want to consider doing a biopsy if the stakes of doing an intervention are very high. So, if a patient has, let's say, only one kidney or tumors in multiple spots, or both kidneys have tumors, or they have chronic kidney disease at baseline, that might be a reason to do a biopsy if treatment is going to put that patient at risk for a significant or meaningful decline in their kidney function. Next slide. If a biopsy is pursued, I think it's worth mentioning that biopsies are generally safe. Complication rates are less than 5% in most contemporary series. And then I'll mention this because this is a question we get a lot. There's really not been any reported cases of tumor seeding or of cancer spreading because of a biopsy. So, this fear that doing a biopsy is going to cause cancer to spread is really not one that we worry much about. Next slide. So that was the first question, which is what is it? So over the next few slides, we'll talk a little bit more about what do we do about these tumors. So next slide, and we can move one more. So these are the management options that are laid out by the AUA guidelines for patients with small renal masses. Active surveillance. I'll talk a little bit about partial and radical nephrectomy. We'll hear about percutaneous ablation, and then I've put radiation kind of in parentheses there, not yet incorporated into the AUA guidelines, but something that is talked about a little bit. Next slide. Okay, next slide. So we'll focus first on active surveillance. So the idea of active surveillance is not that we simply ignore these tumors forever, but rather that we keep a very close eye on them. The rationale for this is because we know these tumors grow slowly. Some of these tumors can grow very slowly, and generally in these small size ranges, the rates of metastasis or the cancer spreading to other parts of the body tend to be quite low. Next slide. So we know this. There's been lots of research studies over the years showing this, but the most recent and probably among the larger studies out there just came out last summer. This was almost 600 patients who were managed with active surveillance across multiple different centers in the United States. They were followed for over 4 years. Next slide. And there were essentially two main takeaways. One takeaway was that this confirmed what we already know from prior studies, which is that growth rates for small renal masses tend to be pretty slow. We typically quote 3 to 5 millimeters a year as kind of the average growth rate. This particular study showed a growth rate that was even slower, about 1 millimeter a year. And interestingly, almost a third of patients in this cohort actually had no growth at all, with a few that even potentially got smaller, but likely just stayed the same. Next slide. The second takeaway from this paper was that again the likelihood that the cancer spread, again these are small renal masses, the likelihood that the cancer spread to other parts of the body during that period of surveillance was very low. So 99.8% of folks did not have their cancer spread. They did not die of kidney cancer. Those tumors grew either very slowly or not at all. And most importantly, for patients who were managed with active surveillance initially and then switched gears and went on to treatment, the fact that they didn't do treatment right away and it started with surveillance did not compromise the outcomes of that treatment. Next slide. So, who should get active surveillance? So, this is again borrowing from our AUA guidelines, but surveillance is really preferred if the risk of treatment or the patient's risk from other medical problems outweighs the risk posed by the tumor. So, if the patient is more likely to die of something else, then we probably should monitor fairly conservatively. The other point here is if treatment itself is too risky for that particular patient because of maybe other medical problems or things like that, that'd be a reason to think about surveillance. Next slide. What does active surveillance look like? So again, I mentioned this is not just ignoring these tumors, but keeping a close eye on them. So we usually start off with imaging maybe every 3 to 6 months, and then we typically tailor the frequency of monitoring to the individual patient and the individual tumor. We often start off with cross-sectional imaging, which means CT scans or MRIs. Sometimes at some point, folks will start to use ultrasound, but that's really dependent on the individual patient. And then switching gears from surveillance to treatment can depend on things like the rate of growth, the size crossing a threshold of 3 centimeters. It's what's laid out in the AUA guidelines, but not a hard criteria. And certainly any changes either in the patient's overall condition or new biopsy information, things like that. Next slide. So that was active surveillance. Next slide. We'll talk now a little bit more about surgery. Next slide. So we'll talk about both partial and radical nephrectomy, but when we talk about surgery for small renal masses, we're really talking mostly about partial nephrectomy. So what is partial nephrectomy? Partial nephrectomy is removing the part of the kidney that has the tumor in it. That's here on the left side, and then on the right side, radical nephrectomy means removing the entire kidney. Next slide. So, which surgery is preferred? So, in general, again, this is our AUA guidelines would tell us that in general, for small renal masses or early stage kidney cancers, if we're going to pursue surgery, partial nephrectomy is generally preferred over radical nephrectomy. And there's two reasons for that. Number one, the cancer control is essentially identical between partial and radical nephrectomy for small kidney tumors. And the second is that over the long run, saving part of the kidney through partial nephrectomy can put patients at a slightly lower risk of developing long-term kidney disease. And then again, the AUA guidelines do mention if a partial nephrectomy is going to be pursued for a small kidney tumor, surgeons should at least consider doing this in a minimally invasive fashion as long as it won't compromise outcomes. Next slide. So when do we really prioritize doing a partial nephrectomy over a radical nephrectomy? I think the answer is if we're worried about long-term kidney function. So if a patient only has one kidney, certainly we want to save as much of that kidney as possible. If there's tumors on both kidneys, if there's multiple tumors in the kidney that's being operated on, and there's already kidney disease, or patients have very young age, or if a patient has other medical conditions that might impact their kidney function in the long run, such as hypertension, diabetes, things like that. Next slide. When should we consider a radical nephrectomy? So when is it better to say, you know what, it's actually safer here to take out the whole kidney? So again, our AUA guidelines would lay out three criteria, and they would suggest that removing the whole kidney is probably better as long as all three of these are met, not just one or two, but all three. So the first is there's no pre-existing chronic kidney disease, meaning kidney function is pretty good starting off. Number two, the other kidney, meaning the kidney that would be remaining after radical nephrectomy, is appears to be normal, and we would predict that that kidney would be able to keep the patient's overall kidney function either totally normal or very close to normal. And then the third, and perhaps most important, is that the tumor itself is very complex, meaning trying to do a partial nephrectomy would be challenging even in experienced hands. If all three of these criteria are not met, generally we would lean towards a partial nephrectomy. Next slide. So I'll talk a little bit about how partial nephrectomy can be performed. I'll show some photos from surgery itself. So if you're squeamish, you may want to look away just for the next few minutes. Here on the all the way on the left side is a photo of open surgery. So that's where we make a little bit of a larger incision and we're able to put our hands in around the kidney and work sort of with what we think of as traditional surgery. In the middle, I've shown a photo of kind of our traditional robotic approach. This is the for folks who have a robotic surgery for their kidney tumor. This is most commonly what's done. It's 4 or 5 little holes across the belly, and we work that way. And then the bottom photo is a little bit of a newer technique, still a robotic approach, but it's a different robotic tool that allows us to do the surgery through 1 or 1.5 incisions, basically. But these are all sort of tailored based on the individual tumor and the patient characteristics. So, next slide. So I'll just sort of show a little bit for those who are interested what it actually looks like when we do these surgeries. So this is that middle photo I showed earlier, a robotic approach using our traditional multi-arm robot. Here we start off the bottom of the screen is the large intestine. So the first step is to sort of move that intestine away so that we can get an exposure to the kidney. Next slide. Then we work on we can yeah, then we work on finding the blood supply to the kidney. So here we've dissected out the renal artery, which is the main highway that carries blood to the kidney. Next slide. Then we go work on the tumor. So here on the top of the screen, the tumor is kind of hanging off the kidney itself. Next slide. We often will use an ultrasound during surgery to help define the borders and to help plan our excision, meaning we can sort of guide in real time how deep the tumor goes into the kidney and sort of plan our attack before we cut out the tumor. Next slide. We then go back over to that blood vessels that are feeding the kidney. We put a clamp on those to slow down or stop the blood flow to the kidney so that we can work safely while we're cutting out the tumor. Next slide. We then cut out the tumor itself, which is shown here. Next slide. And then what we immediately put the tumor into a laparoscopic bag to seal it up so that there's no concern about tumor spilling in the body. Next slide. And then lastly, the photo on the left shows basically what's remaining is a kidney that has basically a crater in it where that tumor used to be. And then on the right side, we've stitched that kidney back up. Next slide. So, what does recovery from, let's say, a robotic partial nephrectomy look like? Folks will typically go home the next day. Uh, Sometimes, in some cases, we'll send patients home the same day. Generally, in terms of their diet, they're going to go back to eating kind of their regular foods that they're used to eating. Most folks, in the vast majority of cases, will leave the hospital without any drains or tubes or catheters. We send people home with a prescription for narcotics. Some people use that narcotic, some don't. Very few will ever need a refill on that. So pain is generally pretty reasonable. And then long term, the kidney that was operated on usually will recover most of its function. Next slide. In terms of outcomes, so the long-term outcomes of surgery for small renal masses or for early stage kidney tumors really depends on the final pathology, but for the most part, depending on the type of tumor, anywhere from 80 to 95% of folks will continue to be cancer-free 5 years later, and we generally monitor for any signs of cancer recurrence with CT scans or MRIs. Next slide. So, as a summary of early stage kidney tumors from a surgical perspective, again, we know renal cell carcinoma is among the top 10 most common cancers in the United States. 80% of small renal masses do end up being malignant, but very few of those have potential to metastasize at their small size. A biopsy of a kidney tumor can sometimes be helpful, but not always. Active surveillance is a safe approach for the right patient. And again, it's not for everybody, but for the right patient, it can be an excellent approach. Partial nephrectomy is generally preferred over a radical nephrectomy for small renal masses if you're going to pursue surgery. I'll stop there and turn it over to Dr. Hibbert.
Thank you very much. My name is Rebecca Hibbert. I'm a radiologist at Mayo Clinic, and it's a pleasure to be here today. I'm a radiologist who does abdominal imaging as well as non-vascular interventions, including ablations, which is what I'll talk about with respect to treatment of early stage kidney cancer. Next slide. No disclosures. Next slide. So briefly, I'll cover what our role is in terms of diagnosis and mostly management of kidney cancer, early stage, so small renal masses. I'll speak about ablations. What is ablation? Specifically, cryoablation, because that's usually the ablation method that we use here mostly for renal masses at our institution. When and why we employ ablation for kidney cancer, what are the advantages, what are some of the risks. I'll talk about patient-reported outcomes and briefly walk you through a visual example to illustrate what that procedure entails, what it looks like. Okay, next slide. So as interventional radiologists, we play a role in diagnosing kidney cancer, as Dr. Khanna talked about, performing biopsies through imaging guidance. But also we can use minimally invasive treatments, so treatments through needles that are inserted through the skin to treat kidney cancer through either extreme heat or extreme cold with needles. We work in close collaboration with our specialist colleagues, so urologists, oncologists, nephrologists, to make sure that we're doing the right intervention at the right time in the right patient, as Dr. Khanna spoke about. Next slide. So what is percutaneous thermal ablation? Well, it basically is a minimally invasive way of treating kidney tumors, but also tumors elsewhere in the body, where we insert needles through the skin using imaging guidance, usually CT scan or ultrasound. And we insert the needle tips into the tumor and apply either extreme heat or extreme cold to destroy the tumor tissue. As I mentioned, you can use either heat or cold, but here we predominantly use cryoablation or cold to treat renal masses. Next slide. So who do we perform ablations in? Typically, the patients will have small renal masses. So these are masses that are under 4 centimeters in size, so the size of a golf ball or less. But on occasion, we do treat larger renal masses with percutaneous thermal ablation in selected patients who are maybe not good candidates for surgery. Ablation can also be a really great treatment option for patients who are at risk of developing multiple tumors over the course of their lifetime, or in patients in whom we're really trying to preserve as much healthy kidney as possible. And as Dr. Khanna spoke about, patients who may have perhaps a previous nephrectomy or have a solitary kidney or a renal transplant. So these are kind of the overall picture of who are patients getting percutaneous thermal ablation. Next slide. Percutaneous thermal ablation has been around for almost 30 years, but you can see here how the volumes have continued to increase over time. And these curves here reflect the fact that we are using mostly cryoablation at our institution to treat renal masses. And this shows up until 2022, but you can see how there's a steady rise over time, and we're continuing to see increased volumes of cryoablation for kidney tumors. Next slide. So how does cryoablation work? What does that look like for a patient? So patients, these are typically done as outpatient procedures. So patients come in the morning, and the procedure is done under general anesthesia, and patients typically go home the same day. During the procedure, we insert a set of needles into the kidney tumor, and there's gas that circulates inside of the needle through a small opening. And the expansion of gas causes an extreme drop in temperature that results in an ice ball that forms around the tip of the needle. And that ice ball is grown over the course of 10 minutes around the tumor. And then we thaw it and then grow it again a second time and then thaw it again before we remove the needles and then wake the patient up from anesthesia. So tissue cell occurs through intracellular ice crystals that form inside the cells and cause osmotic damage and microvascular thrombosis. Next slide. This is just a time-lapse video showing 10 minutes what it looks like when that ice ball grows around the needle tip. And we know that the coldest temperatures happen at the center of that ice ball. And so we make sure that that tumor is really engulfed or embedded in the center of those needles. We also make sure to grow the ice margin or the edge of the ice to a distance a little bit further away from the edge of the tumor to make sure that we really encompass the tumor in its entirety. The nice thing about using cryoablation is that we can see the edge of the ice quite well on CT scan. And so we do these procedures and monitor live with CT scan. We can watch the ice edge as it grows around that tumor and engulfs the entire tumor. And we can also use that to really monitor the ice edge and make sure it doesn't grow into adjacent structures such as the ureter or adjacent bowel. Next slide. So when we treat larger renal masses, we can use more needles side by side in a way that enables the ice to coalesce together and form more of an ice block, we'll say, around the tumor. And on the right-hand side, you can see what it looks like from the outside when we perform these treatments. There's just some small puncture sites, but no large incisions. We can also control the shape of the ice depending on how many needles we use, how we space them apart, and the settings on our devices. Next slide. So, what are the advantages of ablation? Ablation has a high technical success rate. Studies have shown similar oncological outcomes as partial nephrectomy for small renal masses. What patients really appreciate is there is a very short recovery time for these procedures. For most cases, patients will go home the same day and have a rapid return to normal activity. The procedure is very repeatable. And so, if for whatever reason there is a recurrence that occurs down the road, either in a previously cryoablated site or a previously surgically treated site, we can go back in and retreat that small focus as needed. Um, it's also good for treating, we do treat more central tumors as well. And so we've seen patients opt for ablation over surgery, sometimes when there's a high risk of conversion from a partial nephrectomy to a full nephrectomy. Sometimes patients will opt for ablation in that situation. Again, minor cosmetic defect or effect, we don't use incisions. They're just little puncture wounds or like a little small paper cut that heals very nicely. And the advantage too, during these procedures, we can certainly biopsy the mass during the ablation, and we do that certainly if patients have not had a biopsy before the ablation, so that we're able to understand the final pathology of the mass that we're treating. Next slide. There are certainly risks of ablation, and but mostly ablation has a good safety profile. Most important risk is the risk of bleeding, or most common risk is the risk of bleeding. It's about 4% for cryoablation. In most cases, bleeding is self-limited. Uh, there's also a risk of injury to structures around the kidney. And so, for example, when we treat larger tumors that are more central in the kidney, sometimes what we do, or our urology colleagues will place a stent or a little tube in the ureter, and we run fluid in that tube to protect that ureter as we grow the ice around that area. Um, we often use fluid to displace structures around the kidney to ensure that they remain safe from the ice ball. So things like bowel, sometimes the abdominal wall or overlying skin will inject some fluid to try and move those structures and keep them at a safe distance away as we grow the ice around the tumor. So again, very nice safety profile. Next slide. In terms of patient-reported outcomes, we've looked at our ablation procedures here, and Patients do quite well after these procedures. You can see here how in the first couple of days after the procedure, they report a pain scale of about a 2 to 3. Um, uh, and then it kind of tapers down to baseline in the days to weeks after the procedure. Next slide. In terms of overall physical well-being and overall social activities, again, very minor disruption in the days after the procedure, but you can see how there's a rapid return to baseline, or even better than baseline, here on in the next days after the ablation. Next slide. So here's a few case examples. Next slide. So this is kind of our typical percutaneous ablation case. Here's a patient with a 3 centimeter mass at the upper pole of the left kidney. You can see that kind of rounded ball of tissue here circled. And so that's what we're targeting to treat here. Next slide. And so on the left upper side, so this is the patient, a CT scan across the tumor. You can see the tumor circled. And then in the middle image here, the video shows insertion of needles into the tumor. And we'll focus on the bottom left picture now. There's a segment of colon that's really close to the treatment area. And so before we grow that ice ball, we inject some fluid to displace the bowel away from the tumor. And then the bottom image shows the ice ball growth around the tip of the needle. So at the bottom middle image, you can see the ovoid density around the needle tip. That's the ice ball growing around the tumor. And the top right video, once the needles are removed from the tumor, we give contrast to show that there's no sign of bleeding, and to examine the ablation area to make sure that we're happy with the results. And in this case, really nice results shown here. And bottom right video shows this patient 1 year later, where we see just the expected scar-like area at the site of treatment, but no sign of viable tumor. Next slide. And lastly, just to show how occasionally we do larger renal masses, this was a patient who could not undergo surgery, but had a fairly large renal mass projecting from the lower pole of his left kidney. And we treated it in the same manner. Next slide. The only difference from the initial case that I showed is that we use more needles to create a larger ice ball around that tumor. But in the end, we have similar results where you can see how there's no enhancement on the top right corner. There's no enhancement of that renal mass post-treatment. And we have a nice margin at the base where that tumor used to attach to the kidney. And 1 year later, we show no viable tumor in that area. So great result for this patient who could not undergo surgery. Next slide. So in conclusion, percutaneous thermal ablation is an excellent treatment method, especially for small renal masses, but occasionally for larger renal masses in patients who are unable to have surgery, or in patients who are at risk for developing multiple tumors over the course of their lifetime. Again, we use a team-based approach. That's key. We collaborate very closely with our colleagues in urology, in oncology, as well as with patients in order to determine the best treatment and to provide the best individualized option for the patient's situation. And with that, thank you very much for your attention, and I look forward to your questions.